Good afternoon, everyone, and thanks for joining in. I'm Ellen Mason with the California Medical Association, and I will be your host for today's webinar, which is the fifth installment of the Data Exchange Explainer series, How to Optimize Your Practice's Workflows for Data Exchange. Please submit any questions that you have throughout the presentation by using the question box in the control panel located on the right-hand side of your screen. We will go over questions at the end of the presentation and can also follow up after the webinar. Today's presenters are Jeff Nguyen, Senior Director of CMA Physician Services, and Adli Abdul Karim, CEO of Electronic Health Network and Orange County Partners in Health HIE Technology Partner. First, I will turn the presentation over to Jeff.
Thank you, Ellen. All right, let's get this started. So I'm Jeff Nguyen, once again, your host for today's presentation. So I'll go over some highlights of the DXF and DSA updates, but I want to let you know that we, as a physician services organization, support data exchange framework and many of the statewide programs. So happy to be a resource to the audience here about DXF DSA, as well as any other statewide programs like the other little one that we talked about last week, if you joined our webinar last week, which is the Equity and Practice Transformation Grant that does have a component of data exchange in it. But for today, we'll focus on data exchange framework. And I would like to introduce Adli. He's CEO of Electronic Health Network, as Ellen mentioned. Now, just one other thing I would like to highlight is he is working in Orange County, supporting physicians out there and other data sharing partners. So he will be definitely giving some insights about what it really looks like in the field, with real participants. So I encourage everybody to think about some questions as we go through today's presentation. And we continuously seek your feedback. I know it is October. We've been at this for almost 10 months, 10, 11 months now. And so you may feel like you've asked every single question, but I learned something new every day, and usually from a physician practice. So please keep them coming. So there will be, like Ellen mentioned, an opportunity to ask questions by the chat box throughout the webinar today, as well as a post-webinar survey. So there's some free text boxes there too for you to enter any questions you have. And as always, we have our DXF questions inbox there. You can email us there. And we also have a DXF microsite with the resources and a little help box in there too to kind of directly ask a question there. So many ways to reach out to us, and we will get back to you as soon as possible. Most of the time, I get back to you the same day. And so please keep it coming. So for those of you who have been on this webinar journey with us, welcome. Thank you for your loyalty and tuning in every month or so, every couple of months or so to the webinars. The first 4 are on demand now. So you can look up at the microsite, you go to the CMA website and just in the search for DXF, it should pop up. And so the recording as well as the handouts as well is available. And yeah, please, anything, those webinars, if they pop any questions, happy to address those topics again as well offline. So today's webinar is really about how HIEs impact a practice's workflow. And so we know that the workflows that are involved, impacted today, are key day-to-day work that physicians and their staff do. And so we want to really emphasize how HIEs provide some benefits around efficiency, effectiveness. And so it does take work. I'm not going to lie, I'm not going to sugarcoat that, but we want to demonstrate how other practices, how HIEs, like OCPH's HIE, has helped other practices gain efficiencies, effectiveness around patient care coordination and staff effectiveness. The next one that's coming up, it's a little bit free form, but we really want to focus on implementation at a community level. we've heard some feedback around like, what about the other partners? And how do I know who else is signed the DSA? So we're going to be focusing on that in our last installment in December. So it should be exciting. We're hoping to get some good guests from some community-based organizations and potentially some public health partners. So to show at a county, at a regional level, how practices can really get hooked up to a bigger network that represents the medical neighborhood or the patient's care overall. So excited about December's webinar as well. So some quick celebrations and updates around the signatory grant. So you probably have heard me go on and on about this. I will still go on and on about this until it is finally deadline for the round 3. So round 3 starts actually next week. So Monday next week, it starts officially. So if you go on to the DSA signatory grants website today, it says round 2 is closed, but it will open up for round 3. There is no restriction to register because it is going to be a third-party grant portal. So I encourage for everyone who hasn't applied for the grant, just go ahead and register first, get warmed up, save the links. So once it opens up, you're ready to go. Now, big reminder, this grant is for DSA signers, okay? So it can help you with that as well. If you need help signing a data sharing agreement, it was due January 31st, 2023, but you can still sign it. There's no consequences right now for being quote unquote late. So we encourage everybody to take a look at that. 2, if it's been a while, if you don't know if you signed it or not, I'm happy to look that up for you as well. Or if you want to see like what, if you forgot the links or anything, just let me know and I will get you that information. Exciting news. We had heard from CDII, the State Department that is sponsoring this grant program, that the end date is flexible. So it was previously in December. However, they recognize that QHIOs have not been finalized. And so they don't want that to be, they want that plenty of time for the Qualified Health Information Organization, the little orange box there, for as many as possible applicants to be reviewed and hopefully win that title. And therefore you can select them as a QHIO grant option. So there's a lot of flexibility in round 3. So that is the grant, but I want now to kind of switch over to celebrate for those who have won. So I'm happy to say that first round, there was $1.5 million in grants to 25 signatories, so DSA signers. So you see that list there. I'm super happy to know a couple of those and winners there. And then excited to show how much more has won in the second grant. So you see there's a huge mix, right? Independents, FQHCs, specialists. So I really, really encourage everybody to apply. There is approximately still, doing my math here, about $39 million to be awarded. So I believe there's plenty of time. There's hopefully plenty of support you feel, both through us as from CMA, as well as the team there at CDII, the grant team there. Super supportive. I know them all. And then if in anything, I can always escalate any questions that you have about your grant or about the grant in general, but they're very responsive. So this is just the technical assistance grant, the option for, hey, you want to customize it a bit. Maybe you want to do an HIE and you want to do a lab radiology connection. And so this is the option where you have more latitude in the sense is to do what you want with the funding grant. The QHIO, which is still a solid program too, is just more of a highly supported. So basically, you're in this grant here. These winners here have selected an HIE because during this process there wasn't a QHO yet. But what this program is really intended for is that plug and play. All right, you know exactly what HIE you want to onboard. That's really what you only thing that you want. And when you win this grant, they just take care of you the rest of the way. So so this is where it is a more streamlined implementation. Of course, there's got to be things around EHR upgrades and if needed, things like that. But the QHIO that you select, in this case, I'm sorry, the HIE that you select will be in charge of implementing and getting you set up. So once again, great list of folks here that won the QHIO version of the grant. So I hope everybody sees that it's doable, it's not scary. There's about like 4 real questions on the grant, and they're really straightforward. And so I think the dollars that are will be flowing pretty soon for the winners of this grant. And the, like I said, the third round will be open next week, and that will be closed when I believe all the QHIOs, or as many as they can, be selected. But I think that's very super generous of the state to allow that flexibility. All right, so once again, applause. Congratulations for all those who have won the first and second round grant awards. Okay, so on to kind of the more businessy part. So today's webinar is eligible for CME. And so there's this legal disclosure, right? And so please take a second to read that. Okay. Today's learning objectives. So this is really about, once again, how HIEs help practices meet the data sharing agreement. And second, how it protects patient privacy and helps practices share data. I understand that the 2 biggest concerns that we receive from practices, that one, patient privacy. Are my patient data going to be protected? Is it going to be safe? How do I know? So Adley will cover some of those topics, right? And then the other is about, what are the requirements? So have a great webinar led by our legal team around the regulations, but I'll kind of sum it as this. The HIEs and the data exchange framework are governed and regulated by the same sets of laws and regulations. So it is built and it's aligned, and I think all of the team members who helped put together the data exchange framework got a lot of great input by federal entities, by industry, by practices, by CMA, to really make sure that that it aligns. So I have been telling any and all practices that really it is not more than what is expected today from a physician practice. So I just want to say that because I know those are the top 2 concerns we've been hearing throughout the year. All right, so on to today's kind of like topic and guest speaker. And I want to once again introduce Adley, who will be talking about health information exchange and interoperability. And I will hand it off to Adley.
Hello, everybody. Pleasure to meet you all virtually. My name is Adley Abdul Karim. I'm the CEO of Electronic Health Network. Go to the next slide, please. So a little bit about myself. I've worked in operability for over 15 years now in various states, onboarding health information exchanges, worked with the Substance Abuse and Mental Health Administration around consent-driven transactions, and really focusing on 42 CFR Part 2 and being able to drive patient consent-driven transactions for the release of information. Various care management initiatives that involved accessing data from health information exchanges because there are such a wealth of information and data. And currently operating, working in conjunction with the Coalition of Orange County Community Health Centers with their local HIE, OCPH. That HIE really focuses in on providing provider practices with information and data at the point of care. And we leverage some of the national networks, such as Care Quality, and it also has access to that eHealth exchange to be able to access hospital information, discharge summaries. We interoperate and connect to clinic practices, offices, systems, to be able to just make information available for them so that it's easier for them to do their jobs. So the topics I want to cover today are going to be really the purpose and the role of an HIE, consent and the permitted uses of data, integration versus interoperability and why they're different, why it's important, the standards that govern that, touch a little bit upon the national networks, Care Quality, Commonwealth eHealth Exchange, and then the benefits of HIEs, QHIOs, and DXF. Next, please. So the purpose of an HIE. So when we look at the patient's journey through a healthcare system, it isn't linear because the healthcare system just is not monolithic. There's a lot of different stakeholders and participants. So the patient embarks on this journey in order to improve their health. And they visit a primary care. They may have to go to a hospital. They may have to go to the pharmacy to get their medication. And each time that individual touches an organization like a pharmacy or primary care or specialist or a lab, a little bit of information about them is retained in that system. So what we're looking at is like each system is a piece of a puzzle. And what we want to do to provide really optimized care and to provide enough information for whomever is providing treatment, provide the best treatment possible, is to really give them a whole picture, right? Like to really complete that puzzle. And that is really the purpose of a health information exchange or an HIE. It's there to really follow the patient's journey, be able to connect into these systems and present to the users a full picture. All right, next slide, please. So the current state of HIEs and how this information is being used. So it's really important to know that with every transaction that's performed, there has to be a purpose statement within it as to why we're using this information and why we're using this data. So if you think about like just a really simple use case, like I'm gonna call in somebody and say, I would like to make a request for XX information. And they're like, okay, then why do you need this information? Why do you need this data? And then please sign a document consenting to releasing so you can have access to this information. So with an HIE, this is done technically in the background through the transaction. So each transaction has what's called a purpose of use. And it's up to the responding system or the HIE community to really define what purposes of use they will allow for the data to be utilized and accessed. So primarily now it's treatment. There are other use cases, but right now the core use case is treatment, which is pretty broad, which means the data can be used for a lot of different things, such as referrals, discharge summaries, care coordination, lab exchange. So if you think about a patient presented, let's say at an ER, they go to their primary care doctor afterwards, you can leverage the HIE to query and retrieve that discharge summary. So now you have that information for your records and to be able to move forward with whatever treatment is needed post discharge, right? Being able to share that information. Same with referrals. If you want to send a referral, HIEs can play a role in being able to transfer that information necessary or required for referrals, so that you necessarily don't have to fax or use those antiquated means of sharing information. Next slide, please. So there are other use cases where HIEs can be incredibly beneficial. So one example is healthcare operations. So because these systems, HIEs, connect to so many different data sources and have these diverse stakeholders, they hold a very comprehensive picture of the individual and of the population. So there are other use cases that can really help practices. One that I've seen that organizations are really excited about are really leveraging HIEs for retrospective ATC coding, so that you can check to see if it was coded properly, identify those that were not coded properly, fix the documentation, and then be able to have that corrected documentation back into your EHR system. However, in order to be able to perform, this particular use case, the purposes of use is healthcare transactions. Healthcare operations. And the only way that we can execute this particular use case is if all the governing bodies that manages these HIEs have agreed that yes, this is a purpose of use that is going to be permitted, and the use of this data will be permitted for this particular reason. So which is why it's really important to have really a common governing framework that really drives the policy and the decisions that then in turn drives the technology and other use cases that benefit the providers in the community. Next slide, please. So where HIEs are going is really looking at broadly, like what does the healthcare system really need? And it's broader than just being able to provide treatment. There's various administrative burdens. There are new models that are trying to be introduced into the healthcare system. There's new technologies out there for trying to improve patient outcomes. And what they want to do is make it broad enough to where we can cover all of these permitted uses of data and then be able to use the technology to provide the best services possible for all the stakeholders and participants. And this is a direction that the country's taken, also the direction that the state of California is taking, with being able to really have that common framework that expands to multiple purposes of use to really drive a lot of these efficiencies, so that we can look at patient outcomes, we can look at administrative needs, etc. Next slide, please. So now we're going to look at how consent plays a role and how the permitted use of data, in essence, is tied to that entire consent process. So one, the consent has to be, the regulations are going to be established either by the federal government or by the state, right? And these two things can both live at the same time in parallel. And with each transaction that has to happen, a purpose of use has to be specified for why you're consenting for this specific piece of data or this information to be used for, right? And it's important to note that these are all responsibilities of the HIE. So the HIE has to bear their responsibility and the risk for sharing information for the right purposes to the right people, right? With consent definitely in mind. So when a provider or a hospital system has questions about consent, they really need to also work with their HIE partners and understand how that process is being governed, right? With OCPH, we have an internal process where the access controls and the consent process mimics what the policy is that's stated by the OCPH HIE governance board. And they all kind of follow the same pattern, right? There's number one, a law and a policy that drives like the permitted use of the data and what can be done. And then there's a component of informed consent that the patient has to understand exactly why they're consenting in, and it has to be in such a way to where it makes sense to them. And then there's a technology component, and the technologist enforces the consent directives of the patient and whatever laws and policies are in place. So they all three work in tandem so that an HIE is able to manage the consent process. Next slide, please. So with the regulations that drive consent, it's usually going to be an opt-in, opt-out, and then the adherence to 42 CFR Part 2 and SUD data. So most states have adopted the opt-out process, and which means you're automatically enrolled until you explicitly say you want to unenroll from the system. And with OCPH, the way we do it is if we receive information from one of the practices that an individual wants to not unenroll or opt out of services, we trigger that within the HIE, and then from that point forward, information is not being shared. But we also handle sensitive information that's restricted, and for that we enforce the opt-in that lives at the same time as the opt-out, and then the individual has to then opt in, execute an agreement electronically, and that permits then the use of that information for it could be 42 CFR Part 2 or substance use data. And with same thing as before with every single consent transaction, there has to be within that the permitted use, so that it's okay. You're opting in, you're opting out, and what is going to be the permitted use of that information. Next slide, please. All right, now I'm going to transition to talk about connectivity into HIEs and integration versus interoperability, because they are different and one is easier than the other. So integration is a more complicated process. And so we have this diagram here, and if you look at the data being apples and oranges, and you have system A and system B, integration is transforming an apple into an orange. So it's taking data from one system, transforming it so that the other system is able to understand it. And another component of that is, how am I going to transmit this information securely? So you have your airplane, you have your truck, and you have your boat. So you have to agree on a method of secure transport. So once you agree on a method, you then take your information, your data, you send it to this magical integration box. It converts the apple into an orange, and then an orange is delivered to system B that understands how to consume oranges. Interoperability is more of a seamless exchange, because these things have been identified in a standard, and then each system then adheres to that standard. So when system A and system B communicate, they're already going to be speaking apples to apples, and the secure method of how you make that transaction happen, or the communication, has already been established. So then it translates into a more seamless exchange of information and more of a plug and play, making it a lot easier to achieve information sharing in between systems. Next slide, please. So standards and why this is important. So the standards, they define the rules for interoperability that the systems that we use every day have to adhere to. And this is really to try to make interoperability less expensive and easier to maintain. Because whenever you start talking about custom integrations, it can get complicated, and those systems are difficult to manage and to maintain. And then it becomes a lot easier to be able to move the right piece of information to the right system and not be inundated by having or overburdened with too much information, because each system now adheres to the same standards. And the objective and the goal of these national networks, such as Care Quality, Commonwealth, and eHealth Exchange, is to achieve this nationwide interoperability, so that there's number one, a common trust agreement that everyone follows, a common set of standards that everyone adheres to, so that when we connect into these systems and begin to access information, share them, it becomes a lot easier to do. And then now we have the ability to then scale that. Next slide, please. All right, so this is like, why is all this important and how does it all wrap together? So the goal is to try to, as much as possible, enable these HIEs to provide benefits to all the stakeholders. And that's like really taking out the use of antiquated methods of transferring information, could be faxes, and just make it electronic in order to reduce the resource effort, reduce the level of FTEs, and be able to get information that you need faster, right? Really trying to make it at your fingertips. And with DXF acting as that statewide, really that trust agreement, it really defines the who, how, and why. It's who's going to be participating, how they're going to be participating, which really defines like the technology and the technical requirements going to be there, and then why are we doing this, and what is the purpose of use, and how we're using the data. So this trust agreement really lays out all the governance. And then the HIEs and the QHIOs, they really take that from a technology perspective, and they facilitate what's defined as like the governing law. And then that's what enables the information sharing, the patient consent policies and access control services to really simplify the process of being able to leverage these HIEs for information sharing in order to really improve outcomes and try to make the physicians' lives easier by presenting data at their fingertips, and then also expanding into future use cases as they are permitted. Thank you. Next slide. And I believe that is it.
Awesome. Well, before we go into questions, I just want to tell everybody that I love the oranges and apples slide. Maybe because it's lunchtime as well, but I love that slide. And so it makes it just a great depiction of what interoperability and integration is. So thank you for that, Andy, and also a great presentation. All right, so I'll hand it out to Ellen to help us with the Q&A session.
Perfect. Thank you both. Here's our first question for Adley. Can you tell us more about how you're working with Orange County? What kind of support or services can practices expect from their local counties?
Absolutely. We work with them at all levels. That's from initially helping them understand the benefits of the HIE, what are the requirements for being able to onboard, down to a lot of technical assistance with working with the vendors to establish the interfaces, launch the applications, and then ongoing training and support, so that it's really easy for them to navigate this entire process with folks from our team that can help them in every stage of the process, and then ultimately giving them the applications and tools they need to really be able to utilize the HIE for the desired use cases.
And maybe I'll add on too, from that county question, is that every county is a little different, but we're happy to do some digging and get you some contacts about maybe it's the local initiative health plan that supports Medi-Cal. It could be a public health agency. We've seen many county stakeholders step up throughout the year, not just for DXF, but to make sure there is some type of data exchange. And so happy if you want to hear specifics or get in contact with your local county leaders on that, happy to share that too. So just send that question to our DXF questions at CMA Docs inbox.
Will major software vendors have to provide HIE services?
I can take that. A lot of major software vendors do provide some level of interoperability, and some also act as HIEs. An example would be such as Epic. Epic does have their Epic Everywhere product, and they act as an HIE, but also they use that to facilitate connectivity into other exchanges and data share. So I would say most vendors are now developing their technologies with an eye towards having an interoperability first solution, knowing how important it is to be able to share information for care coordination and patient improve patient outcomes.
Did CMA publish a list of assisted pathway vendors yet?
CMA has not put a vendor list together. forthcoming, we will provide a kind of decision support too on HIEs. We are friends with all of them. Once again, friends with all of them. And so we can put you in connection to their leadership and their support team to learn more, get demos, cost quotes. So definitely can do that. So I would say maybe there's two main vendors to talk to as folks are kind of exploring onboarding to an HIE, for example. Like one, your EHR vendor. And if you're on paper base, hey, if this is a great time, the grants can be spent to onboard you to any EHR if you believe that's the best option for your practice. So that's one, the EHR provider. And second, then is your HIE options. We love all our HIEs. I always recommend the local one if there is a local one available in your area. And the main reason why is that HIEs are not brand new. And so many of the HIEs have worked locally, like OCEPH has laid the groundwork. So I really want to give a nod to those who kind of laid down the foundations around this work and introduce those first. But everybody has an option, and we'll connect you to those resources. So we're not publishing a preferred list, but look out at our DXF microsite next week. We're going to put together a decision guide with all the HIEs that we know of. We're going to keep that updated as the QHIO results come out from the state, and we'll flag them like this is this HIE is a QHIO vendor. Also, later next month, we'll put together an EHR decision support too as well to help you get your contacts and kind of out of the box data exchange capabilities kind of summaries as well. Great question.
Oh, I do want to add one more thing to that. When EHR vendors are great, and in looking at EHR solutions, it's really important to understand their current interoperability and data sharing functionality that they have available. Because oftentimes folks will select systems and then think about connecting those systems into HIEs or QHIOs at a later date. And that becomes quite complicated because then they find out, oh, well, this vendor doesn't quite have exactly what I needed to connect in. So identifying that on the front end prior to making a decision is incredibly important so it's not forgotten about.
Totally agree. And I know because I want to add this one in, think also beyond the HIEs. If you do have a local lab that offers some type of integration that's very specific, right? But you really find it that if you find that will be very useful for your practice, that's probably the third kind of like to do is kind of look at like what other partners, right, in care that do offer some type of integration as well, and ask them like what they use and what they prefer. That'd be a great part of your kind of due diligence to prepare for that.
So, do we just wait to see if our software company will provide what we need, or does CMA know who is currently developing systems?
So we do know at the top line all of the major EHR software and what they can do. So we're going to put that summary together. We do know of, for example, we've been talking to Office Ally. I know they're very popular, and they do support HIE integration. They're very generous with their time and expertise. Lovely folks there. They do not have current plans for any bi-directional. So what does that mean? That means like actually getting data into Office Ally's EHR. So they will facilitate connecting to share data like out of your instance of Office Ally, but not right now. Currently is available, like what Ali was saying, they don't have the capability of actually bringing data in. So we'll be sharing that and with a summary of their quote unquote out of the box capabilities, including if they can do bi-directional, which is I believe is maybe not the future, but it's basically now. That's kind of like growing as a standard capability.
With OCPH, we have worked with Office Ally, so we do receive data from them inbound, and we actually work with them so that we're able to launch the OCPH user interface from within the Office Ally, a single sign-on. So it doesn't necessarily bring the data directly into the EHR, but it does simplify the workflow, because then you can click a button in the Office Ally EHR. It pops up a web page that then has the HIE data there.
Thank you, Adley. And hopefully no one thinks it's a bad thing, because it's different strokes for different folks. I just want to kind of use that as a highlight, as that we've been talking, and definitely HIEs that are on top of it, like OCPH, partner with all the major EHRs.
Are all IPAs or medical groups required to be an HIE?
Under the data exchange framework, it is a no. Maybe I'm thinking the question is coming from maybe participating within HIE. So from the exchange framework, IPAs are one of the signatory groups that are required to do data share, to sign the data sharing agreement. There may be some pushback here and there about like what a physician organization is, but from CMA's perspective, we have encouraged IPAs to sign, and we believe they fall under that signatory group. But as far as I know, and you can correct me if this, you're up on it more than I am, IPAs generally will participate in an HIE and have their own instance, and maybe offer that service or help their contracted practices participate in HIEs. But I don't believe many IPAs elect to become an HIE or offer their own homegrown product. Right, Adley? Just want to check me on that.
I agree, yes.
Okay, thank you.
Will you have another session like this to share the findings of EHR vendors?
We haven't planned it, but let me note that. And I think we're happy to have more of a technical, especially when all this information is new, and for the implementation, timelines. So just a reminder, everybody, for practices that are more than 25 physicians, compliance with the data sharing agreement is by January 31st, 2024. For those who have less than 25, compliance date is January 31st, 2026. So we do plan to keep pushing out updates and resources throughout this year. But that's a great idea. I think once we get the EHR and the HIE, QHIO updates, I think it will be a great topic just to share that, walk it through, and really kind of maybe take some more kind of use case examples as well. So we'll take note of that, and that'd be a great topic.
Will there be more grant opportunities further down the road? It seems early for a 2026 deadline to file for a grant right now.
As of now, there is nothing planned from the state for like a fourth round. Like I mentioned earlier, if those join a little late, is that the third round starts Monday, October 16th, and there is no end date due to not having the QHIO's final list or the first round out just yet. And I would encourage that those who may need it, just any thought, just like I might need this, just go ahead and apply. I understand it's 2 years, but there is lead time to consider. So what both Adley and I have mentioned, research your EHR, your HIE options, and then there's contracting, and then there's really making time for you and your staff to get trained and onboarded. So that will easily take up a year, easy. Okay, and so we want to make sure you have plenty of time to decide as well, and then because there are resources and dependencies to get it actually implemented and data flowing, the 2 years will be quickly consumed. So I don't, so, and then I understand that 2 years out feels like a long time, but I think it's better to have the money, and then you do have for the QHIO grant 1 year to implement. For the technical assistance grant, we have 2 years. So it's kind of baked in a bit for in the program that all of this decision making and timing is needed. So it's great that you have the money, right, to spend, and then plan as you go, right? So I have not heard once again if there's another round of funding. So please treat this third round as the last and final opportunity.
Who collects the HCC data and for what purpose?
Adley, you brought it up. You answer it.
So that's an example of like a real world use case that we were trying to work through, to where you have your national networks, such as like Care Quality, that has connectivity into a lot of the hospitals, and some of the practices may wanted to do HCC coding, and it's for risk adjustment. I think it was for Medicare Advantage. But the issue is that with these national networks, such as Care Quality, healthcare operations yet is not a permitted use case. So although the data, a practice, theoretically could have access to the data via the HIE to be able to do the risk adjustment, in all actuality, they could not, because it wasn't a permitted use of the data based on the current regulations. So that's why we're looking at the next slide, which is the future state of HIEs. As we expand on the purposes of use of data, it becomes a lot easier to be able to do things like retrospective coding, HCC coding for chart reviews, as an example.
Yes, and I know I was joking with Ali a bit, but let me add a bit here. I think most of the physicians on the call, practices on the call, know what do you call it? Hell every day in spring, HEDIS, right? So about that time where everybody's chasing charts from you, right? This will be helpful, right? If you have an HIE facilitated as data, health plans and their reps and their contracted vendors will be chasing you less. They probably will still chase you for some stuff, right? But they'll have that data. And
yes,
two is that you have that data. And so with a lot of vendors and software vendors out there can help with this risk scoring. So those who participate in Medicare Advantage and really know this stuff, and like I mentioned, I was jokingly, it is something cyclical and you have to go through it. So this is also, like I said, I think an opportunity to lessen the workload during that intense period, for example. But broadly speaking, a pop health perspective, knowing the complexity of your population you're taking care of, this is great. This is your data. This is your patient's data. And I will add that this is more and more the expectation. So NCQA, who governs or produces those HEDIS specs, is adding or is moving away from chart reviews. Everything has to be claims encounter based. So just what I know, Adley's adding some context around, like it's about the purpose. It's still developing, and we need all of those that framework to make sure this is approved by all parties. But this is the movement. And I think this is where I want to reframe it, that this is your patient's data, your data too. So it's not just about giving it to the health plan and getting a score, but really this stuff here is really helpful to manage your patient population.
If we are a smaller group or solo practice, can we start the application process before we sign the DSA, since not required until 2026?
So let me unbundle that a bit. So from a grant perspective, it's open for everybody to start now. And there's understanding that urgency is make sure you get all the larger practices, come on, sign up, right? And the state understands this. So they'll definitely I want to look out for supporting those that go live in January, upcoming January. And I think I heard from the DSA perspective, data sharing agreement, that's two separate portals, okay? So you cannot apply for the grant if you do not sign the data sharing agreement first. So do that first if you haven't done so.
How does your HIE allow patients to opt out of having their data?
Could you ask that again, please? I cut out for a second.
Sure. How does your HIE allow patients to opt out of having their data shared?
Absolutely. So it comes in two parts. So one part is a technical policy that mimics what the law is, right? So we have on the back end a technical policy that says this individual does not want to share any information. So therefore, if a query is issued, respond with no data found, right? And we have the same thing for opt-in. And for us, we've built this out into an API so that as an HIE, we want to be able to be very cognizant that the mission is to really to drive interoperability and simplify connectivity and certain things that technologies and systems need to do. So the way we do it is that if someone goes to their provider and they want to opt out, they tell their provider. That then is communicated to OCPH, and then they, in essence, just trigger a function to publish an opt-out document, and then that opts out the user and no information is shared. So we leverage the standards in order to drive that consent process.
Ali, maybe I just want to pair back what you just said and from a process perspective. So from a patient is first needs to be aware, right? Is that the physician's, the provider's responsibility to say, and I know most have a form of some sorts, but that's the first step, correct? That they know that their data is being shared through an HIE.
That's correct. To know that their data is being shared and that they have the options to opt out, and that sensitive information is not being shared, and they have the option to share it, to opting in.
Okay, got it. And so at that point, that's where they later. So let's say they say, yeah, that sounds good. They want to opt in, and they're good with it. And then later on, they would have to come back to talk to their provider and say, I've changed my mind for various reasons. And that's where it triggers the steps you had mentioned, that the provider office will go ahead and communicate that to OCPH. Is that correct?
Correct.
Okay, and then so I'm going to put you on the spot here. So is there a way, kind of a self-serve perspective from a patient, to just, log in or email OCPH somewhere to say, can you make sure that I don't want to have my information shared? Is there a self-serve type of option?
We don't have one at this stage, but I think that's something that we are working towards to make it more of a self-serve model. Really, the technology supports it. It's really not just aligning like a process, a business process to facilitate.
Awesome, thank you, Adley. Yeah, I know I'm putting you on the spot because I know it's one of those things that where physicians have asked me that, right? And so it's kind of a redundancy that let me kind of step back. I think we promote patient privacy, and we want to make sure that physicians have every tool possible. And so I think if your OCPH, other HIEs have heard that, definitely endorse that feature. It'll be super helpful.
Will HIE allow non-DSI signers, or excuse me, DSA signers to participate and share data on their exchange?
So that is a great question, and I need to get back to folks on this. So what on the details? Because there is going to be a directory of sorts that show all the DSA signers. And so from that DSA signers can go in and say, oh, I just want to double check the people I work with or I trade exchange data, see if they've signed it. So that's going to be out there forthcoming. The state's going to publish a list. So hopefully it's kind of an easy kind of web type of tool. As of now, we have not heard of any requirements that participants in HIE right now are either flagged as DSA signers or if there are limitations of how they participate. So that is my homework to do. It's a great question.
Okay, our last question for the day. Can I still sign the DSA? How can I confirm the state has received it after I sign it?
Yes, you can. And so I'm going to skip a bit to the resources slide. So you can go on to the DSA grant. They'll have make sure you sign a DSA grant. It takes you to the portal. You can email me. You can go to the state's DXF microsite, which has a bunch of information. You scroll down a bit, you'll find the link, okay? And you can sign up. It's and there's a help feature to the upper right. Click it. There's a document with screenshots to help you out. If you want to confirm, right, even after you do it, you just don't trust the system, you send me an email and I'll double check. And if you thought you've signed it and just feel kind of like not sure, you can still email that inbox right there, dxfquestions@cmadocs.org, and we'll look it up for you. No problem.
Perfect. Well, that's all the time that we have for questions today. Thank you so much to both of our presenters. We recorded today's webinar and it will be available on demand on our website tomorrow with a link to download the slide deck. All of our upcoming webinars can be found on the CMA homepage or at cmadocs.org/events. Our next webinar on December 7th is the final one in the Data Exchange Explainer series, Incentives and Other Funding Opportunities for Data. Recordings of past webinars can also be found on the CMA website at cmadocs.org/webinars. Contact us at events@cmadocs.org with any questions that you have. Thank you.